Hello, it's Mark Kris from Memorial Sloan Kettering. Speaking today about a recent meeting in New York by the New York Lung Cancer Foundation, their summit meeting called a Call to Action. This meeting was organized by Fred Hirsch, Tony Mock, Solange Peters, and Paul Bunn. And it specifically was looking at critical issues in lung cancer therapy from screening to diversity, and trying to find items that needed emphasis, that needed research, and to prioritize them. It was a wonderful meeting, and it included practitioners of all specialties, regulators from the FDA and EMA, representatives from patient advocacy groups, and also representatives from pharmaceutical companies. And one of the topics that they dealt with is one that's sort of near and dear to my heart, and that is the use of neoadjuvant therapy. And you've heard me speak on this before. But it seems that the huge discussion today is still adjuvant versus neoadjuvant. And I just want to clarify a few items here and to get people thinking about how we're going to move this forward. Number one is that please note that there is no direct comparison data for patients in your office with stage 2 disease, whether they should get surgery followed by adjuvant therapy or whether they should get neoadjuvant therapy first. There is no direct data. So we're dealing with something that is sadly not going to be data-driven, and we're going to have to rely on our best synthesis of the data that we have. The second thing is that people say, oh, the outcomes are comparable. Well, they're not comparable. Please remember, only the patients that have successfully had surgery are the ones included in the adjuvant trials. That's not the same group of patients included in the neoadjuvant trials. And you really can't compare them. And there isn't a comparison, say, from the time of surgery that just hasn't been done. The last thing is, and just to share with you what happens in a clinical trial. And the truth of the matter is, you cannot rely on a patient that's clinically stage to get adjuvant therapy. And here's some numbers. I was involved in the trial by the Lung Cancer Mutation Consortium, LCMC3, and this was a trial of neoadjuvant therapy. We had 181 patients enter this trial. All of them virtually got the neoadjuvant therapy. But between the time of neoadjuvant therapy and the surgery, a quarter of them did not go on to surgery for a bunch of reasons, not the topic for today. Of those people that went on to surgery, 137 of them, only 85 got adjuvant therapy. So that's less than half of the patients. And when you look at it overall, it was 85 out of 180. So if you're saying that for that patient in my office where I'm making that decision, here in this real-world trial where chemotherapy was available to everybody, where these were generally fit patients for surgery, a minority of them got adjuvant therapy. So please remember, there's a huge fall-off at each step along the way, and that clinically staged patient in your office, at least by the data available today, is very unlikely to get guideline-recommended adjuvant therapy. Again, that is particularly chemotherapy. It needs to be rethought of then now that we have adjuvant therapy as well. The second thing is that people are not focusing on in this area is the science behind it. So please note, in the preclinical studies in lung cancer and in breast cancer, when you compare the use of adjuvant to a neoadjuvant approach, neoadjuvant therapy resulted in better outcomes. Same therapy given before or after the surgery, neoadjuvant was better. There's also the data from the early trials, this unexpected improvement in outcomes when you gave the checkpoint inhibitor at the beginning. And first it was that trial from Ford and Shaft, those first 20 patients where there was a tremendous benefit, unexpectedly, frankly, from single-agent nivolumab. And by the way, they've reported on that trial since, and they've shown that that benefit has been increased. So there's data there. And also there's the data from other diseases, and that's the data in melanoma, where they gave the same number of checkpoint inhibitor cycles either some before and some after, or all after, and there was a clear benefit to the patients that got the results before. So all the data today points to where you have to make that decision for the patient sitting in your office. Neoadjuvant is the way to go. And it's frankly covered by guidelines. If you're going to the NCCN guidelines today state if you're going to give neoadjuvant therapy, you need to give it, if you're going to give adjuvant therapy, rather, you can give a neoadjuvant therapy. And the last thing that had happened at this meeting, it was one of the surgeons who was present, Nasser Al-Turki, made the comment that what's really important here is the immunotherapy. Getting that immunotherapy response is the way to increase cures over surgery alone. And please remember, for all those stages, surgery can't cure. Also, giving it as soon as possible, and the preclinical and clinical data that giving it before the surgery makes sense. So you really got to give that neoadjuvant therapy. You have to give the checkpoint inhibitor neoadjuvant. So I think the data's there. The early clinical information is there. And lastly, there just is no information that's going to say that it's a better approach to operate and give adjuvant therapy, because the facts would say the majority of patients are not going to get adjuvant therapy, even when it's part of a clinical trial where it's part of it. So I hope this argument can keep moving forward and that the benefits of neoadjuvant therapy are clear. There are now FDA-approved treatments for this. And I urge folks to always have it on the table, not right for every patient, of course, but always have it on the table.